First of all, I would like to thank the organizing committee and Dr. Arun Garg sir for inviting me again for a talk in this conference. Happy to be here. So, my talk today is on one of the more common problems that you all are going to handle in your outpatient department, diabetic peripheral neuropathy. So, diabetic peripheral neuropathy is the most common form of neuropathy in developed countries. If a patient comes with neuropathy to your outpatient department and if he is a long standing diabetic, the dictum should always be don't conclude that it is due to diabetes, because up to 50% of patients with diabetes can have other additional causes of neuropathy, and many a time these may be treatable. So these may include B12 deficiency, alcohol induced neuropathy, to name a few. If a patient comes with newly diagnosed diabetes, at that time itself, the prevalence of neuropathy is around 20 to 25%. Many of it may be subclinical. If there is no neuropathy at diagnosis, even in a well controlled diabetes, neuropathy can develop. Up to 50% of patients may be affected by 20 years. So, what are the risk factors for developing neuropathy? The most important one is poor glycemic control. Longer duration of diabetes, older age, tobacco use, other things also contribute. There are many proposed classifications for diabetic neuropathy. Diffuse neuropathy, which will include your most common distal symmetrical peripheral neuropathy, mononeuropathies, radiculopathy, and of course, what you should watch out for, the non-diabetic neuropathies which are treatable or reversible in a patient with diabetes mellitus. So I would urge you to look at it more like whether it is a non-inflammatory neuropathy or is it an inflammatory neuropathy. But also keep in mind that even in diabetic routine neuropathy, it has been demonstrated that there is a inflammatory aspect which is present. So first of all, you have a 74-year-old man, diabetic hypertensive for 15 years, history of alcohol use. He has presented with paresthesia in the form of numbness affecting lower limb. And for the past 3 months, he has numbness involving the hands also. Clinical examination shows normal power. The ankle jerk is absent bilaterally. There is a graded sensory loss to touch, mildly diminished joint position sense and vibration sense, and Romberg's is negative. So a predominant graded sensory involvement. So this is your routine, normal, what you come across, a distal symmetric polyneuropathy and a large fiber variant. So 75% of cases of diabetic polyneuropathy will be a distal symmetrical peripheral neuropathy. So the prevalence we have already discussed. So in a large fiber variant, you have a painless paresthesia which gradually ascends up. So it's a length dependent neuropathy. Once the neuropathy ascends up to the knees, then you will have involvement of the hands also. The reflexes may be diminished. Initially the ankle jerk, followed by, if the advanced neuropathy, there are other reflexes also. The sensory deficits, like I mentioned, will be length dependent. So initially the foot will be affected, and once it ascends up to the knee, you have hand involvement. And in advanced cases, there can be sensory involvement of the trunk also, with sensory loss in a wedge-shaped pattern involving the anterior trunk and abdomen. The motor involvement is minor. In very advanced neuropathy, you can have motor involvement, mainly patient may be ataxic. And based on the duration and severity of neuropathy, you can have autonomic symptoms also. Electrophysiology will demonstrate a predominantly axonal neuropathy, which is more in the lower limb. So there will be reduced sensory amplitude and also a reduced CMAP, more in the lower limb than in upper limb. Treatment. So treatment per se is, of course, strict glycemic control. And also you should make sure that you address the other aspects of metabolic syndrome. Hypertension, hypothyroidism, dyslipidemia, whether the patient is overweight. So adequate exercise and good diet has been shown to reverse diabetic peripheral neuropathy in a large number of patients. Pharmacotherapy, which is mainly useful for the painful variant, may be less effective in a large fiber neuropathy, which is this variant. So the second case, we have again an elderly lady who has long-standing diabetes. She is overweight. She has presented with a positive sensory symptoms in the form of pins and needle sensations. This has again ascended up. She is not able to walk without her chappals due to pain. She complains of resting tachycardia, palpitations at rest, and also some pre-syncopal symptoms. Examination shows a tachycardia. There is an orthostatic drop in blood pressure. There is a skin involvement. The foot is dried and cracked up. Motor examination is normal. There is hyperalgesia to touch. Investigations show uncontrolled diabetes, a normal nerve conduction study, and your autonomic function testing shows abnormality with impaired autonomic reflexes. A skin biopsy was done which shows reduced intraepidermal nerve fiber density. So there are multiple differentials in this case, but of course the most common cause of a small fiber neuropathy is still diabetes. So here you have small fiber involvement causing painful peripheral neuropathy and an autonomic neuropathy as evidenced by sinus tachycardia, orthostatic hypotension, and pseudomotor dysfunction. So the small fibers include the thinly myelinated A delta fibers and the unmyelinated C fibers. So these are responsible for the pain and temperature sensation and also autonomic function. So the patients will present to you with both positive sensory symptoms in the form of hyperesthesia, allodynia, and negative symptoms in the form of impaired touch and temperature sensation. Posterior column sensations will be usually well preserved, and you have a normal nerve conduction study in majority of the patients. Of course, keep in mind that the patient can have a mixed small plus large fiber involvement. In that situation, you will have an abnormal nerve conduction study. There are multiple investigations available, but the standardized investigations will be a skin biopsy. You can see here a non-diabetic patient who has got a normal intraepidermal nerve fiber density and a diabetic patient in whom there is reduced nerve fiber density. Corneal confocal microscopy, that will be a less invasive investigation, and they have found that the assessment of the nerve fiber density closely correlates with the intraepidermal nerve fiber density. So it may be an option to avoid an invasive investigation. Where do you take the biopsy from? So the biopsy, we have already discussed that diabetes produces a length-dependent axonal neuropathy. So to demonstrate that involvement, the biopsy will take usually from two sites. One will be the distal leg, 10 centimeter proximal to the lateral malleolus, and proximal site in the lateral thigh. So it has very high diagnostic accuracy. So the diagnostic criteria of small fiber neuropathy in diabetes. So if you have the definite small fiber neuropathy, there will be length-dependent symptoms which are mainly the positive sensory symptoms, clinical signs of small fiber damage, a normal nerve conduction study, and the biopsy which shows a reduced nerve fiber density. Again, here also the main thing is good glycemic control. And also you have to address the metabolic syndrome. In this group, which constitutes about 15 to 20% of distal symmetrical peripheral neuropathy, your pharmacotherapy comes in handy. The duloxetine, venlafaxine, the SNRIs, tricyclics. You should not combine ideally the SNRIs and tricyclics. And of course, you have pregabalin and gabapentin. Many a time, monotherapy will not suffice. You have to go for a combined or a polytherapy. And in difficult cases, the topical treatment works. Capsaicin ointment and patch is available, which can be applied up to 3 to 4 times depending upon the patient's tolerability. Alpha lipoic acid has shown benefit when given for periods of 6 to 8 weeks. And in refractory cases, you may even go for TENS or spinal cord stimulation. It is always advised to avoid opioids, but in some situations, maybe at least on an SOS basis, you might have to resort to use for pain relief. So autonomic neuropathy, again a manifestation of small fiber neuropathy, depends upon whether the severity of the somatic neuropathy and how much duration the patient is having. So the patient may present with cardiovascular involvement, gastrointestinal involvement, genitourinary involvement, or pseudomotor involvement. The cardinal features of a cardiovascular autonomic involvement will be with a resting tachycardia, which is the earliest sign. And in addition to this, the patient can have an orthostatic hypotension with a drop of 20 millimeter of mercury on standing up. There will be a diminished heart rate variability to respiration and to Valsalva maneuver. So, what happens in an autonomic neuropathy is that there is a vagal denervation of the heart. So, the lack of parasympathetic effect leads to increased unopposed sympathetic activity. So, there is a resting tachycardia. When the neuropathy advances, this heart rate usually settles down and the patient will have a fixed heart rate which does not change with change in position, with respiration or Valsalva maneuver. So these patients are also prone for asymptomatic cardiac events. So it's important that you in your OPD you identify, because at the onset of diabetes itself, around 10 to 15% percentage of patients may have autonomic neuropathy. So the standardized testing is not there, but what you should address is that to assess the heart rate for a resting tachycardia, whether there is a heart rate variability with respiration and Valsalva, and assess for orthostatic hypotension. Pseudomotor abnormalities, as we saw in our patient, had a distal anhydrosis and a proximal hyperhidrosis. You should not try to correct the hyperhidrosis with the therapeutic maneuvers, because the patient can have tolerance issues. Gastrointestinal and genitourinary involvement due to autonomic dysfunction can occur. Gastrointestinal patient can even present with the diarrhea or with the constipation. Genitourinary involvement patient can have impaired bladder sensation, incontinence. So this is the autonomic testing. Majority of it is not standardized. Cardiovascular we have already mentioned. For pseudomotor you have the QSIRT, the thermoregulatory sweat test, and the skin biopsy. Gastrointestinal by assessing the passage of barium. So the treatment, I'll come to the treatment of the orthostatic hypotension per se, which is more clinically what you see in your outpatient department. Remove all possible causative medications like diuretics, drugs with anticholinergic effects. Ask the patient to have lifestyle modifications. Don't get up suddenly. Make sure that you take water at regular intervals. Increase fluid intake, increase salt intake. A coffee with the meal might help. More frequent meals. So if you have a heavy meal, there is a chance of the blood being directed to for the digestion. So avoid having large meals, have frequent meals. The compression stockings and abdominal binders may help. And in difficult cases, you may go for medications, including fludrocortisone, which because of the mineralocorticoid effect causes fluid retention. And you have midodrine, which by the alpha-1 agonistic activity causes vasoconstriction. Now coming to the third case. So a 30-year-old man who presented with shoulder pain, polyuria, he was diagnosed to have diabetes. It was uncontrolled. So he was started on treatment. 1 month after being started on insulin, patient presents with a positive sensory symptoms and some autonomic symptoms. We check the blood sugars and the blood sugars are under control. So in a period of 1 month, this young fellow with treatment has developed a neuropathy. Now conduction studies are normal. So he has an acute small fiber neuropathy and an autonomic neuropathy. So this is your treatment-induced neuropathy of diabetes. So usually happens in young patients when you go for aggressive control of diabetes. So don't try to control very fast. A more than 3 reduction in HbA1c over a period of 3 months, the patient can develop a small fiber neuropathy with autonomic neuropathy. It usually happens in young patients. Earlier it was called insulin neuritis, but we are aware that now it can happen due to even oral hypoglycemic agents. It begins abruptly, and one good thing is that it will settle down with good glycemic control in majority of the patients. When you consider neuropathies which can occur due to treatment, you should always keep in mind the possibility of B12 deficiency, which develops secondary to metformin use, which can again lead to a distal peripheral neuropathy. So here you have again an uncontrolled diabetic patient who stopped his medications, had weight loss, and then had severe pain involving the hip and thigh, and then he developed weakness along with wasting. Clinical examination shows an element pattern of weakness with absent reflexes, initially the knee jerk. So this is a typical presentation of a diabetic lumbosacral radiculoplexus neuropathy. It's known by multiple synonyms. Majority of will be using one of the things. So the first described one was the Bruns-Garland syndrome. So here it is more frequent in males and type 2 diabetic patients, and usually it happens after the age of 50 years. And it can happen in different clinical scenarios. It can happen in a patient whose diabetes is uncontrolled. It can happen when you initiate the patient on treatment, or it can even be the presenting symptom of diabetics in some patients. Usually it starts with an asymmetrical proximal lower limb weakness. There can be territorial spread, and the patient can develop gluteal muscle weakness or even a foot drop. And if not treated, or even with treatment, it can spread to involve the other limb. Usually we see a significant weight loss in these patients, and the patients can also have autonomic symptoms like we have mentioned. So this is thought to be an immune-mediated inflammatory site. The investigations show uncontrolled diabetes, and the neuropathy, when you do your electrophysiology, it is an axonal neuropathy. That is where there will be a prominent wasting. EMG will show a neurogenic pattern with a denervation. Your MRI will show hyperintensities involving the nerve root and the plexus. CSF analysis can be normal but may have elevated protein with normal cells. So whether to treat or not treat these patients, that is the confusion that is there, because many patients
Dr.
spontaneously
Kurian, we
improve.
have 2 minutes to conclude.
Many patients spontaneously improve. But some patients are left with the deficits, so we usually tend to treat these patients with either IV immunoglobulin or with steroids. After the initial treatment, patient is not put on continuous treatment and they tend to improve. So diabetes can even present with CIDP. So what we have seen is that CIDP is more common in patients with diabetes, up to 10 times more common. Usually diabetic patients will present with a CIDP at a later stage, and they usually present with typical CIDP. So the mechanism, it is thought to be due to the chronic hyperglycemia, and also there can be antibodies which are directed against the peri-islet Schwann cells and also against the peripheral nerve Schwann cells. So always make sure that you don't overdiagnose or you don't underdiagnose CIDP in a patient with diabetes. So diabetic peripheral neuropathy itself, the patient can have a demyelinating neuropathy. Sometimes even protein can be elevated on CSF analysis. So in that situation, you should not overdiagnose CIDP. And of course, CIDP is a treatable cause, so you should diagnose it. And the how to make sure is that the CIDP with the diabetes, it presents in older patients. Autonomic dysfunction, which is not usually seen in CIDP, it may be more common in a diabetic patient with CIDP. The axon loss will be more severe in diabetic patients, and hence the outcome also will be not so good as your routine CIDP patient. Treatment, predominantly we go for IVIG. Corticosteroids you can give, but you should carefully control the blood sugars. Long-term treatment with corticosteroids again might be difficult because of the underlying diagnosis of diabetes. Patients can present with truncal neuropathy, usually involving the T4 to T11 dermatome. And this is usually seen in type 2 diabetes mellitus. Some patients can have bulging of abdominal wall and we can mimic a hernia. Again, this is also usually self-limited. After some time of good treatment, the truncal neuropathy will settle down. Limb mononeuropathy can occur due to two mechanisms, either nerve infarction or entrapment. How to differentiate these two will be nerve infarction will be abrupt onset with more severe pain. There will be axon loss, and the outcome there will be wasting. Whereas your entrapment neuropathy, which is most commonly affects the median nerve, you have a gradual onset. There is a demyelinating neuropathy, and there is not much wasting. And finally, an uncontrolled neuropathy due to the distal peripheral neuropathy can have a diabetic neuroarthropathy with a Charcot foot, where the treatment will be offloading. Pharmacotherapy is useful, like you treat in osteoporosis with bisphosphonates and calcitonin. So to summarize, Glycemic control is the key in prevention and management of diabetic neuropathy, and always address the metabolic syndrome which is present, and make sure that you don't miss the diagnosis of inflammatory neuropathy, which may be treatable and reversible in your common diabetic neuropathy. Thank you.